Your poster about the impact of second-line treatment in advanced pancreatic cancer patients clearly shows that 2 lines of active treatment result in a higher overall survival than continuing with BSC only. Which therapeutic sequence, first, second, third line, makes most sense to you in fit patients and in less fit patients, and why?
Well, I am Dr. Guido Giordano from Italy. Well, pancreatic cancer is a lethal and aggressive disease. Despite of the improvement of survival that we have observed during the last few years with the introduction in clinical practice of new schedules like FOLFIRINOX or the Nab-Paclitaxel plus Gemcitabine combination. The IMPACT phase 3 study has showed that the combination of Nab-Paclitaxel and Gemcitabine improved overall survival, progression-free survival and response rate if compared to Gemcitabine alone. A further post-hoc analysis of this study has shown that second line may impact on survival and patients who received second line may benefit from such treatment. That's why in Italy we have performed this kind of real-life experience, collecting data about 250 patients who had received first-line Nab-Paclitaxel plus Gemcitabine, and we looked and analyzed the outcome of second-line treatment after disease progression during this schedule. Also in our experience, second line had a strong impact on survival. In fact, patients who had received second line treatment had a significant longer overall survival than patients who had not received treatment for second line. And looking at this data, we can think about a sort of strategy for treatment sequencing in pancreatic cancer patients. And how can we imagine this strategy? Now, looking at the evidences and the regulatory authorities in Europe, we have approved as second-line choices oxaliplatinum-based schedule, and in the very next future we will have also the nanoliposomal irinotecan schedule. So our choices may shift between oxaliplatinum doublets with 5-FU or capecitabine or irinotecan second-line treatment choices. Another smaller option is FOLFIRINOX, which is more aggressive and should be performed in few selected patients who are very fit and who had not experienced toxicities to first-line treatment. Our data show that a possible treatment sequencing could be performed in PS01 patients, so in fit patients, using, for example, oxaliplatin or irinotecan second-line treatment, according mostly to the first-line experienced toxicities during Nab-Paclitaxel plus Gemcitabine. For example, patients who had experienced GI toxicity or hematological toxicity should be more suitable to receive oxaliplatinum second-line treatments, while patients who had experienced, for example, neuropathy during first line should be more suitable to receive irinotecan. So thinking about a sequencing or a strategy, we can imagine a Nab-Paclitaxel plus Gemcitabine first-line treatment, followed by oxaliplatinum or irinotecan based on first-line toxicities, and if there is a space for a third line of treatment, we could use the non-cross-resistant schedule different from the one we had used before. This is for the PS01 patients. It is very different for PS2 or frail patients, because a more aggressive treatment in first line is not allowed in all patients. Even if, in my opinion, and also looking at our real-life experience, Nab-Paclitaxel plus Gemcitabine should be performed also in this subgroup of patients. But after progression to this kind of treatment in first line, we should evaluate if a doublet or a single agent could be performed. For example, if a patient who had PS2 respond to first-line treatment and is performance status improves, maybe this patient could be fit for a doublet in second line, and maybe there should be a space also for a third line. If the patient remains PS2 also after first line treatment, maybe a single agent 5-FU or capecitabine could be the best therapeutic choice.